Hello everyone, and welcome to the PowerPoint for this week. We will be talking about case conceptualization and treatment planning. We'll begin with case conceptualization. This is a practice in which you will engage throughout each therapeutic relationship that you maintain with a client. Though there are many definitions, the key components of case conceptualization are developing an understanding and working hypothesis regarding the causes and the maintenance factors of the client's symptoms and current level of functioning. Case conceptualization also entails organizing and synthesizing psychosocial, behavioral, and emotional information and assessment of the client, and then also designing and implementing the plan or strategy for intervention to promote growth and improved wellness. This plan and strategy will be in alignment with the client's needs and abilities to facilitate healing, and will also be proactive in identifying barriers and developing plans to effectively navigate around these barriers. This plan will also grow out of a specific theoretical framework or lens that you have applied to your conceptualization. This theoretical framework or lens will be chosen based on what you are drawn toward, but also what is a fit for the client. There are many benefits to case conceptualization, starting with the mere fact that when we conduct intake assessments, we're given an enormous amount of information. I often tell my clients that the intake is helping me to draw the outline of their story, and then throughout our subsequent sessions, we will begin to fill in the outline with color. Your case conceptualization helps this outline to take form and make sense. It also directs you as the counselor toward the specific areas you will want to color in first and the interventions you will use to do so. Additionally, as we discussed in our last week's PowerPoint, clients can often feel isolated and alone in their journeys toward mental wellness. Being transparent with your conceptualization in ways that will help your client gain a better understanding of their presenting concern and normalizing their concern can facilitate client empowerment and also allow the client to release some feelings of isolation or self-shaming. Additionally, collaborating with your client in this conceptualization will build rapport. Working with the client to make meaning of their current experience and to develop meaningful goals will enhance the trust and the openness in your therapeutic alliance. There's a feedback loop of case conceptualization, and you can see it on the screen here. This was adapted from the book as well. But we begin with assessing the client's symptoms, problems, and resources. Then we move to conceptualizing client concerns through the use of an appropriate theory, and we also include considerations of culture and personal identity as well as developmental level. Then we'll move toward developing a treatment plan and determining the components of an appropriate treatment. The implementing of the treatment plan is followed by monitoring the effect of the interventions, and then we cycle back to assessing our work, and then we work our way back through this loop. But of utmost importance throughout this process is that we are always developing rapport with our clients, evaluating the relationship between the counselor and the client, constantly assessing for safety, and then considering our own biases and assumptions as counselors. I want to jump back real quick to that consistent assessment for safety, because a client's level of safety or risk for suicidality or self-harm can shift throughout your treatment. So you want to make sure that you are checking in if there are any red flags that come up. For example, a client stating something vague like, I just don't want to be here anymore, or I want it all to be over. You want to really use specific language to assess, and then continue to assess as you're gauging your clients, hopefully leaving more severe risk and going into more moderate or mild risk, or maybe no risk at all. But this is always going to be something that's important that will come up through your courses and through your supervision, that you just need to be sure that you are assessing for safety. And you'll be able to open that gate to assessing for safety more easily if you have strong rapport and trust within the relationship. Something that I think we would be remiss if we didn't mention is the component of prevention in our treatment planning. In our conceptualization and eventual treatment planning, we want to ensure that we're operating from a stance of prevention, not waiting until symptoms are at their most severe before intervening. Through case conceptualization, we gain an understanding of what we're working with a client to prevent, and we set the stage for the client to access empowerment in their care. This video from Mental Health America advocates for early intervention and offers a PSA encouraging the public to intervene sooner rather than later when symptoms escalate and grow in severity.
Our brains control how we act in the world, but did you know the world around us also affects our brains? Our genes, environment, and social interactions all work together to shape the way our brains develop. Sometimes these factors combine in ways that create unhealthy thoughts or feelings. Over time, these unhealthy thoughts and feelings become so unmanageable that we need outside support to get better. 50% of people will develop at least one mental health condition during their lifetime, and half of those people will develop a mental health condition by age 14. Unfortunately, it takes about 10 years for people to get the treatment they need. We don't wait to treat health problems like heart disease or cancer until stage 4. We shouldn't wait to take care of our mental health. The right early treatment can change lives, reducing school dropout rates, hospitalization, incarceration, and unemployment. Imagine what the world would look like if we all got the help we needed when we first started showing the early warning signs. Start the conversation before stage 4. Visit mentalhealthamerica.net to get informed, take an online screening, and better understand your own mental health.
So, like we processed last week, Mental Health America is a really wonderful organization. I would encourage you again to go and visit their site. But I think that video is really a strong example of advocacy for the component of early intervention and prevention. So in terms of prevention, I want to leave you with maybe a consideration in regards to your signature assignments. How might you address prevention in your signature assignments? How do you want to do this? Is it a part of your plan? And if it isn't, is it maybe something you want to integrate? So we would also be remiss if we didn't consider avenues of advocacy for mental health. Some questions that can impact client access to care and our provision of care are as follows. 1, with regard to demand and access. Why do so many people who need services not receive treatment? Why is there a need that maybe is sometimes not met by entrance into counseling? And what are some of the barriers that prevent entrance into counseling? And I think that this requires that we take more of a lens that incorporates social location and inquires about access to resources and how lack of access to resources can also bar access to our own services. In terms of quality of care, why does some treatment not meet acceptable standards of quality? An example of this might be that there are still some folks who are offering conversion therapy as treatment for LGBTQ individuals, though every medical, psychological, counseling, health organization has condemned this type of treatment. It is still available out there. Additionally, we want to ask what are accepted standards of quality for mental health care treatment. In terms of reimbursement for services, we want to ask if payment for mental health care should be based on problems or outcomes. Another question to consider is, could providers of mental health care be incentivized to offer better levels of treatment by a type of reimbursement system that focuses on outcomes? And is it fair to providers to base the pay that they receive on their client outcomes? In terms of considerations for stakeholders and power holders within society and the mental health care system, we need to ask who are the key stakeholders in the mental health care arena and who makes decisions about mental health. And I think this is an important question to address with advocacy on that political level and on that legislative level. In terms of competition between professionals, and this is something that I imagine you all will experience in your careers, but you're also talking about in your courses, is why does it appear that there might be competition between different mental health professionals, maybe between psychologists and counselors? Who gets to provide treatment and what types of treatment do they get to provide, and who can complete what kinds of assessments, and who can be on insurance panels. These are questions that we need to ask that, again, tie back into opportunities for advocating for change and for wider access for counselors to provide services. And then additionally, this goes back to the slide that you just watched, the funding for proactive versus reactive care. So we need to ask ourselves, how much should be spent on prevention and how much should be spent on intervention or reactive care? Right now, we do not have many incentives for preventative care. I do believe, and this is my own opinion, but I do believe that we really need to incentivize preventative care because, again, if we intervene earlier, it can stop the progression from one's illness to a more serious and severe stage. So in terms of treatment planning is a part of client conceptualization, but this is a plan or a map for the progression of counseling. So this is really going to tell you what's going to happen in your counseling sessions, what will happen in each session and across sessions. This is a counselor's individualized plan for addressing presenting concerns that the client brings into counseling. This is hopefully going to include integration of your client's thoughts and needs, really collaborating with your client to devise this plan. It will also include expected outcomes of interventions. Treatment planning can also include collaboration with other professionals. For example, in my current practice, I work with a Chinese herbalist and acupuncturist, and sometimes if clients are wanting this type of treatment, we might blend some counseling with acupuncture or Chinese herbs. With clients who are experiencing pretty severe depression, if they would not like to go the Western medical model route of medication, they can get an appointment with the herbalist and consult with the herbalist about what kind of herbal interventions or acupuncture interventions can maybe alleviate some of their symptoms of depression. But something that is very important about treatment planning is this is not just for insurance companies. It's not just for clients. Really, it's also for us as counselors because it allows us to really sift through the information that we're given by our clients and streamline a plan that addresses the needs, recognizing that we might not cover all areas of need, but it allows us to prioritize and to clarify our direction for each session. So in general, treatment plans combine attention to symptoms, awareness of cultural context, and then client input with an intervention plan that's based in a theory. A solid treatment plan is going to include problem statements, and this is going to be generated from diagnosis and from assessments that you do. You will ask yourself to generate these statements, what is the problem or diagnosis, and then what kind of techniques and assessments are available to you. A solid treatment plan will also include goal statements, so short-term objectives, long-term goals, and then the likely outcome or prognosis. So certain questions that can help you formulate these answers are, what are the short-term goals? What are the long-term objectives? And then how is this client likely to experience healing as a result of the treatment and the treatment processes? Additionally, in a treatment plan, you'll include objectives and interventions, and these will be interventions that are based on your objectives. So these interventions are going to be very much aligned with your objectives. Some considerations as you're formulating your objectives and interventions are to ask who might be the best person to help this client. Is it going to be you as a counselor? Is it going to be you working with maybe a psychiatrist? Maybe, like we talked about last week, you're going to want to refer out for a physical evaluation from a medical doctor so that we can rule out any potential causes of the problems that we're seeing arise when the client comes in. Additionally, you're going to want to ask where is the best place to provide treatment for this client, and we will talk about this in a few of the future slides. And then also, will other services or people be needed to assist in treatment? Again, it is going to be key to incorporate your client in this treatment plan every step of the way to really uphold our ethical principle of autonomy, letting that client know that they are in control of selecting a plan that is going to best benefit them and to best facilitate their healing. Now, there are some limitations to this in terms of safety, and we'll talk a little bit about that later. So, looking at our objectives specifically, I want to really break down the components of solid objectives. So not only a solid treatment plan, but solid objectives within it. We're going to be using the model of SMART goals right now. And a goal needs to be specific and stated in behavioral terms. This also applies to when we're identifying any obstacles to the treatment as well. So, for example, if a client is engaging in some risky drinking, let's say that they're not at a level where they have a dependence on alcohol, but they are having more than the recommended amount per week. We want to make them aware of this, and if they are motivated to try and shift this, we want to explore what it might look like to cut back to only 5 drinks across a week. Let's say right now they're drinking 10. So we would use that behavioral to say, okay, we are going to cut back to 5 drinks this week. That also makes this objective measurable. So this goes right in line with stating a specific objective in measurable terms. This can be measured by the use of scaling, behavioral shifts. A behavioral shift would be reducing drinking from 10 drinks a week to 5 drinks a week, and also maybe shifts in frequency. An area where scaling is really useful, and this kind of goes back to assessing for safety. If you're having a client who is consistently expressing suicidal ideation, maybe they don't have a plan for harming themselves or ending their lives, but they do say that they often have thoughts. We want to go ahead and break out a scale of 0 being no thoughts whatsoever, suicide is not even close to being on the mind, to 10 being I am having thoughts, I have a plan, I have means and access to the means, and I will engage on this plan when I leave here. So 10 being pretty certain that they will attempt to end their lives, and 0 being that suicide is not even in the equation for them. You want to check in each week with where they are on the scale. So maybe 1 week they're at a 5, and for them, a 5 might mean that they are consistently thinking of suicide, that they've thought about a way that they want to do it, but they don't actually have plans to follow through on this. They're able to find reasons to not end their lives, and they're able to verbalize these reasons to you in session. So they also might not have access to the means. That could be a component of the 5 there. And then the next week you're going to want to check in. Did they go up to a 6? Maybe going up to a 6 means that they've looked into how they could obtain access to means. They don't have it yet, but they're getting closer to maybe taking action, which could then facilitate them harming themselves or ending their lives. So what you're going to want to do is be very clear on this use of scaling so that you can track any shifts between the weeks and then continue to reassess for safety. You also want to make sure that your objectives are attainable. So we're going to want to use scaffolding. We're not going to tell a client that they need to meet a goal that is kind of like at the end of the line. We're going to want to enable them to take steps toward it. For example, if I have a client, and we have an example of a treatment plan with a client who's wanting to go back to AA meetings after they've been abstinent from alcohol for 2 years, but they're starting to feel a bit tempted to drink again. So a plan for them in terms of attending an AA meeting. Let's say this client's also very much isolating themselves and they're refraining from reaching out when they need help. And maybe they have some social anxiety, they're not able to kind of make that first connection. We're not going to tell them, okay, next week I want you to come back here and tell me that you have attended 3 AA meetings. That's not going to be attainable, and it's not going to be realistic for them. What we might say is, okay, so how about over the next week, you just get on the computer and explore which AA meetings are in your area. So this is taking a step toward eventually going to an AA meeting, but it's not requiring that they get to that end goal before they're ready and before they have developed the coping skills and resources to do so. So this brings us to the realistic piece of an objective, that this does have to be practical for the client. with their current level of resources and their current level of functioning at that time. This will shift as you work toward building toward goals that might require more, because you are also going to be working with a client to equip themselves with the tools that they need to achieve these. But for the time being, we need to make sure that those goals are realistic. And additionally, we want to make sure that they're time limited, recognizing that we will check back in on 1 week if they have looked up meetings in the area. And that's going to be our first step. We're not going to put out there that they have to go to a meeting. We're just going to say next week, in 1 week, you will have looked up 3 possible meeting times for an AA meeting in your area. So hopefully that makes sense in breaking down the ways that those objectives can manifest. But also when we think about outcomes, we want to ask some similar questions. So when we think about developing these outcomes, we want to ask, what do we want to happen as a result of treatment? What are the resources needed to achieve objectives and goals? And how do we help the clients access these? And we need to recognize that our treatment plan is a systemic approach to counseling. It helps us track progress, and we as counselors need to demonstrate that we are accountable in our implementation and then evaluation of the plan. So on this slide, I have a sample treatment plan, and if you want to go ahead and pause to look over this addresses some of the things that we mentioned, or that I mentioned in the last slide. So you can kind of look through, you see that there's problem, diagnosis, some long-term goals, some short-term goals, interventions that will meet these goals, a time-limited target date, and then a prognosis. So please feel free to pause your slides here if you would like to review. So you will find that often in your work with clients, they're going to have differing levels of treatment and care that is needed at different times. When it comes to a client's potential risk for self-harm or suicide, or maybe current substance use or addiction needs, their level of support in their living environment is going to shift. So the levels of treatment are listed on this slide from most restrictive to the least restrictive. Most restrictive being inpatient hospitalization, where they are in a hospital, they're being monitored and observed by a team of doctors and mental health care providers, and they are receiving access to daily, group, individual, sometimes recreational or art therapy. A step up from that are some day programs where clients might go into treatment for a part of the day and then leave to go home at night. There are also crisis residences and then supervised housing where they are living with supervision, but this is in a lower level of restriction and supervision than hospitalization, so it's kind of a step down. You then might also have intensive outpatient where medication management is involved, so this is going to outpatient therapy every day of the week or every other day of the week. So it's really ramping up the intensity and the frequency of outpatient treatment. But this person is living on their own. They do not have supervision and they are not currently in a hospital, but they're also going to be potentially on medication to try and facilitate their access to healing. Then we step down even more to outpatient medication management and counseling. So this is not intensive. This might be once weekly counseling while they are on meds. And then finally, there's counseling without medication. And so you're likely going to work with clients on different tiers of this level of treatment and care throughout your time. But the most important thing is that we want to make sure we engage and involve the client in every step of this decision-making process to encourage agency and autonomy. However, like we mentioned before, depending on safety needs, we must sometimes require more intensive levels of intervention and more intensive or restrictive locations of care to ensure safety and well-being. So finally, I want to leave you with a few tips for treatment planning. So we want to remember that as counselors, we're operating from a wellness model. Our case conceptualization and treatment planning needs to be focused on heightening wellness, maintaining developmental awareness and helping people reach the most ideal developmental level for them, and then also engaging in preventative measures. We also operate with a person-first mentality, meaning that we are not treating diagnoses, we are treating people who have a diagnosis. We're not essentializing the person to actually be their diagnosis. We're allowing people to externalize this diagnosis so that they can also release some of the stigma and shame that comes with it. For example, using person-first language is a way to do this. So not saying, yeah, I'm working with a schizophrenic. It kind of hurts me to even say that, because it's totally taking the person out of the equation and reducing them to this one experience of their lives. So we might say instead, I'm working with a person who is diagnosed with schizophrenia. Additionally, we need to recognize that our counseling relationship and the rapport that we build is vital to maintain. We've got to attend to this counseling relationship and rapport in all stages of treatment. This will allow us to intervene in appropriate ways, in ways that maintain the client's wellness and safety. And again, let's just make sure that we are collaborating. We are balancing out some of that imbalance of power that occurs when we are sitting with a client, and we are including them in developing their treatment plan. We're including them in consultation regarding diagnosis and conceptualization, and we're taking their feedback seriously. So if we're working with a client through one theoretical lens and it doesn't seem like it's fitting, we're going to explore how the client feels about this and adapt our approach to better meet their needs where they are in that time. So treatment planning can be an incredibly effective way to engage with clients and to build your approach to your work with them. This is going to be something you will engage with throughout your time as a counselor, and you'll get more opportunity to do this in future classes, such as your diagnosis class, your assessment class, and then also our gender and sexuality class. So thank you all for joining me today, and I look forward to engaging with you on the discussion board this week.